Hi, I'm Sharon Levine. I'm the section head for geriatrics here at MGH. And I was, Susan came on to the ABIM Foundation board just as I left. We didn't have a
Oh,
chance to.
fantastic. So I'm Karen Sapuka. I'm at the Health Decision Sciences Center. We're housed in the DGIM. So I do research around shared decision making. So excited to be here.
That it's like so important in geriatrics, especially because of the shitty data for all of these things.
Well, yes, the lack and
Breast
lots of
cancer,
options.
especially. Yes.
Yes, yeah.
Lauren, I just made you a co-host.
Judy, I have to. So everybody, I have to. I'm at the Association of Directors of Geriatric Academic Programs is overlapping with this, so I'm going to hop back and forth. So I'll introduce, hop out, and then come back in a little bit.
So can I just ask a quick question? Today, I'm introducing Sharon, Matt, Karen, and Lee, right?
Yep.
Okay.
And
Hi, Matt.
hi. Oh, hold on, Matt. Lauren and Karen, whose slides are they? Can you?
So I have the slides.
Okay, can you pull them up and just let's make sure that they work?
Yep.
And
Great.
Karen Lee is also presenting, right?
Yes. So I know she's doing patients this morning. So she's
Okay.
we talked. So she is definitely presenting.
He's
see.
coming.
Great.
Okay, so let me know if you can see.
We can see. Yep.
Okay.
Just be sure to put it on the slide. Yeah,
slideshow.
Perfect. That's great.
Okay, and then it'll flip through, right? Yeah. Okay.
Yep. Perfect. Okay, you can close those for a minute. And Monique, since you're recording, what do you do? Put it on speaker?
Exactly. Yeah.
And I have slides to share too.
Oh, you want to try it? Great.
All right, let me just, it's just sort of, the way I've decided to do it is just sort of a primer of, this is what senior health is. So let's just go over it. It says one participant can share at a time. All right.
Oh, Karen, can you unshare?
No, I got it.
I think I stopped.
No, I got it. So can you see it?
Yep.
Yep.
So I'm just talking about communication.
Wait, can you make it a full screen? So
Oh,
we don't see
absolutely.
the
Yeah, I was
slides?
yeah.
There you
Perfect.
go. Okay, great.
Did you want to see it all or no?
No. Well, only if you want.
No, I'm just going to say, I'm going to talk about the how to communicate with us, who's leaving, who's coming, what's the style of our practice, what is a medical student, resident, and fellow,
Oh, great.
rowboat versus a cruise ship in geriatrics, principles of the geriatric team model, and that's it. So,
Perfect.
yeah, cool.
Great.
I'll stop sharing. Okay.
Senior health going to be known as geriatric medicine?
I have no idea. I'd
Okay.
like it to be.
There's just so many
No,
name
I
changes
think-
going
I
on.
think-
I don't know what to call anything.
I think you wanted MGH Geriatrics.
That's what I wanted, but I think we were like, this is like, tastes great, less filling. I don't really care as long as we get rid of senior health.
I think your MGH Geriatrics is fantastic and says it all, and you can fit it at the top of everything.
Yeah.
And the tagline per Christine's edits is affirming aging.
Right. But
And people
Susan,
know what geriatrics is.
Susan, today is just senior health
Okay.
because we haven't changed it yet.
Okay.
No, we're not going to do it until we know the move.
Yeah.
Okay.
Okay. So nobody would know what the heck we're talking about.
Well, they think you were a different practice.
Right. It'd be like, what?
I mean, I
I'm
can
evil,
tell you
Dr.
the
Russell.
moves and
You
the
worked with
mergers
good
and-
Dr. Russell before.
Yes. With the moves in primary care, it's been a nightmare for our patients to understand.
Oh, really?
Oh, yeah.
I'm sure it's a nightmare for the docs and the
Yeah.
staff
Oh,
too.
it's a nightmare for everybody. Trust me.
All of our patients are hearing about the move and they know, so everybody knows we don't know anything yet. So I feel like we've done the pre-messaging fairly well, but
They're worried about the parking. Oh, the parking is so convenient. I said the parking will be convenient where we're
the
going.
parking is so much better. Oh my gosh, it's so much better at Yawkey.
And
Yeah.
the eating too.
Oh, I know. Well,
And you can have a valet at Yawkey
Exactly.
if you want. So we're missing Lee. We're going to open in a few minutes.
What order are you going in? Because I didn't print out the one you sent me, Judy. I just have the one that you, that I got.
Well, you're just,
No, but wait, who is, it's Lee and,
I'll
and
be
Karen.
right back.
what order are they going in?
Karen?
Yeah, so I'm going to go first and then Lee
Okay.
for our section.
Okay. And it looks like we'll hopefully have about 20 or 30 people coming on, which is great for senior health. I think a lot of the people, Matt, who were on before were all about COVID, and everybody is calmer about that. So that's a good
Yeah.
thing.
It's also, just, I don't want to be a womp person, but on our loneliness clinic today, we only had 2 people show up. It's just a gorgeous day.
Success.
I was just going to say it's a
That's
beautiful day.
success.
It's like, what are you sitting at a computer for on a day like this? So I think naming it, laughing about it is more than reasonable. I mean, this is just something that I think is important for us to keep going, but I don't expect we're going to have the huge numbers in the summer.
And the other thing is that we are, it's recorded and people actually do go back. We've
Right.
had, we have the analytics and people do
Right.
go back and really look at it. So
Yeah.
it impacts more than who arrives.
Well, and the other thing is that anybody that goes on the MGH YouTube site, whether they're a senior health patient or not, or a primary care patient, can watch these, which is terrific.
Oh, yeah. No, it goes on the Dementia Care Collaborative
Yeah.
and on the Palcare Geriatrics site and on YouTube. And so it's all over the place.
Yeah.
What do you think? Karen, do you want to text Lee?
Text her, yeah.
He's not on for a few minutes, so we can open it, let them in. Sharon
Who's
can
going, who's going
welcome.
for, Karen's going first though, right?
I'm going first. I mean, worst
Yeah,
case, I'll
but-
do it all, but yeah, it
It's
would be
good
lovely for
fun.
her to be here.
It's a good 5, I know, I hate that feeling, but it's a good 5-7 minutes after we let everybody in. So it's a good 10 minutes till
Okay, great.
you guys start. So we're fine. We'll just,
Matt, just a quick update. I got an email this morning from Pediatrics, and they're going to be doing a town hall on all the questions that parents have about COVID vaccines.
Here's
And
Lee.
pardon?
Here's Lee.
Oh, perfect.
Oh,
Great.
good. And they have already gotten 250
Oh, yeah.
questions.
Oh yeah.
oh, geez,
Questions? Oh my God.
questions.
Which
Don't
is
worry,
great.
They're not
it's-
250 unique questions.
No,
That's
no,
the
no,
important thing.
they're not. They're not. But just the fact that they've gotten that much interest and
Yeah.
are doing the town hall, I'm thrilled.
Yeah, I mean, this is sort of the next
Oh,
frontier.
Wonderful.
Yeah.
Great.
I was not planning on talking at all about COVID, so don't throw questions my way, other than I thought we were going to do are we going to do the CDC website?
Yes, feel free to. Lee, you can unmute now. Great. Hi, welcome. All right, you guys, we are going to get going. Karen, when you put your slides up, are they the slides for Lee also?
Yeah,
And
we
you're
just have
gonna-
one. We'll just have one slide deck. I'll just forward them for her.
Yep,
And just
perfect.
to be clear, Sharon, you're opening and then I'll do all
Yep.
the housekeeping and whatever.
Yeah.
Okay.
Mhm.
All right.
Beautiful. All right, here we go. We're welcoming everyone. Admit. Welcome, everyone. We're delighted you're here on this gorgeous day, and we will be starting in just a few minutes, just making sure everybody can get in and all of that. Okay, we'll give it another minute. You can see that you are in the correct room because it's Senior Health Town Hall. And today we have excellent speakers about, do I still need that screening now that I am over 65? So I think that, let's look and see. It looks like everyone, oh, welcome. It's great to see everyone. Great. All right. Sharon, you want to take it away, please?
Sure. Hi, everybody. It's great to see you all. I know that this is our hardcore group, and those of you who can get out on this beautiful day, I hope you're able to get out and enjoy this wonderful day. But until you do, welcome. And we have a wonderful topic today, which is, do I still need that screening now that I'm over 65? And we have wonderful speakers to answer that question for you. So I'm going to pass the baton over to Susan Edgman-Levitan, who will introduce our speakers for today. Great to see you all and happy to have you here.
Great. Thank you, Dr. Levine. My name is Susan Edgman-Levitan, and I'm the director of the Stokel Center for Primary Care Innovation at Mass General, and I'm going to be the moderator today. So before we get started, just a few housekeeping rules. Everyone on the call, except people speaking, is muted because we found that that's really helpful to eliminate any background noise that can sometimes be distracting. You can view the speaker on your full screen, or you can go to the gallery view in the upper right corner and click on gallery view, and that will allow you to see all of the different participants on the call, including the speaker. If the picture of the speaker or the slide starts to get jumpy or out of sync, click stop video in the lower left corner. That will turn off your camera, and that often helps to speed up your connection. For questions, please use the chat feature in the bottom ribbon. It's right in the middle. We also just want to caution everyone to not share any personal medical information or ask any personal medical questions in the chat, because everything in the chat can be seen by all of us. But if you do have a medical question, please reach out to your doctor directly. We really look forward to your questions, and so please don't be shy about entering them in the chat, and we'll do our best to answer all of them. And if we don't have enough time, we'll do our best to get you information after the call. So with that, I'm now going to introduce everyone. So you've heard from Dr. Sharon Levine, who is the section head for geriatrics at Mass General Hospital. Today's speakers are Dr. Karen Sapuka, who is the director of the Health Decision Science Center in the Division of General Internal Medicine, and Dr. Lee Simmons, who is the medical director of the Health Decision Science Center, and close friends and colleagues. So I'm very excited that they're here today. And you're also going to be hearing from Dr. Matt Russell, who is the medical director for senior health and also the director for ambulatory care in the Division of Palliative Care and Geriatrics. So with that, let's get started. And I'm going to turn this over to Dr. Sapuka.
Great. Thank you so much for that introduction. I am going to share my screen and share some slides that Dr. Simmons and I will be using. Okay. So as you heard, we are going to be talking a bit today about, do I still need that cancer screening test? And most of us are probably quite familiar with cancer screening. There are lots of different tests that we get at a regular basis, and these are really important tools to help us find cancer early. And sometimes they can help us prevent cancer and really make a big impact in our health. For many people, the discussion around these cancer screening tests is pretty limited. Often it's just, well, it's time for your test. Why don't you schedule that mammogram? Time to book that colonoscopy. So there's not always a lot of discussion. As you probably know, no test is perfect. There are pros and cons to all of the tests that we might offer as part of medicine. And those pros and cons also might change over time As we get more information about our experiences, if you have 3 negative colonoscopies, your chance of colon cancer is going to be a lot lower. And the cons might change over time. So periodically, it's worth revisiting whether it still makes sense to do these tests and whether that balance, those trade-offs, do they still make sense? And so we're going to talk a little bit about that today. Now, the interesting thing for many cancer screening tests, there are guidelines that tell us when we should be doing these, how often we should be doing these tests. And at certain ages, the guidelines shift. So for example, this is an excerpt from a guideline for colorectal cancer screening. And so it says in adults age 76 to 85, this should be an individual decision, taking into account a person's preferences, their overall health, and their prior screening history. And really what this recognizes is that someone's risk of getting cancer might be very different. Their overall health, the health issues that they might face could be very different. And their preferences, how they weigh those things might be different. And so it might lead someone to continue to screen, and it might lead someone else to say, you know what, this doesn't actually make sense for me at this time, and they might stop screening. Now, this requires shifting the perspective and the kind of discussions that we have about screening. Oftentimes, we don't spend a lot of time with this in the visit. Maybe you just get a recommendation that it's time to start or time to do it. And a lot of times, even on the patient side, we hear from patients, well, if my doctor tells me to have the test, I'll go do it. It seems like a fine thing to do. But what we really want to think about is shifting that perspective and really focusing on a bigger discussion around whether or not to have this test. And so when we hear from some of our physician colleagues is, really what they're thinking about with these discussions is, I want to listen and guide my patients, explaining the options, pros and cons, and then making sure that they're doing the test or not doing the test, if that's what they decide, for good reasons. So when we talk about shared decision making, this is the sort of model that we're thinking about. Now, one of that piece of those guidelines was talking about someone's personal preferences. So what do we mean by that? What does that mean? And for cancer screening, you might start to think and reflect on how worried are you about cancer? How important is it for you to try to find this early? And that might differ depending on whether you have a family history of some cancer, what your prior screening tests have found. Some people might be quite worried, others not at all. And then putting this into the context of, what's important for you in your health? How does this fit into your health priorities? Some folks might have lots of things that they're doing, and this is just one too many. Others, this might be a very important part and something that they have the time and energy to really focus on. And then the one thing that we might challenge you guys to think about today, I'm not sure if anyone's ever asked you this before, but how would you feel if your doctor told you that you could stop screening, that you were done, you've completed it? We have done some work with lots of patients and done lots of interviews. That's the kind of research that we do. And so when we ask patients that last question, we heard a really wide range of responses. So we heard many people saying, well, some kind of screening is necessary. Why would you give up something that might help you? And we heard others saying, well, I'd be relieved. I do it for the medical benefit, but I certainly don't enjoy it. Still others might be connecting to their family history, so something that they want to keep going with. And then others who would be very happy not to have to come back for the test. It'd be wonderful. So when we're thinking about personal preferences, it's thinking about how do you feel about the tests that we're thinking about? And you might feel differently about, for a woman, you might feel differently about your mammogram than your colonoscopy. And for a man, might be different about their PSA test or the lung cancer screen that you might be doing. So you don't have to feel the same about even each cancer screening test, but thinking through how do you feel about this? How important is this to you? And when we're thinking about stopping something, so the research that we do is involved in decision making, and starting something often feels different than stopping something psychologically. So we often probe a little bit in terms of helping people think through their reactions if we sort of play some hypotheticals for folks when we're trying to help them with a decision, if they're maybe wondering how they feel about these trade-offs. So we might ask them, well, if in a few years you notice some symptoms, we order the test and we find a cancer. Now, obviously, nobody wants to find a cancer. That's not a good outcome, but how would you feel about that? And what we heard is that some people would really be kicking themselves that they didn't have that test earlier, whereas others would actually be relieved and say, you know what, I know I'm having the treatment only because I really need it. And so, putting yourself in these buckets can also help you think through, am I really confident that if I stop, I'll be fine no matter what happens? Or, maybe I should be thinking about keeping going. So I'm going to turn it over to my colleague, Lee Simmons, and she's going to start to go through some details for some of the guidelines for this specific types of cancer. But I want you to be thinking in your head as you're listening to that, what are the options? And thinking that there might always be some options now that we might think about for cancer screening. What are your priorities? How do you feel about the option or the thought of stopping screening at some point, whether it's now or maybe some point in the future? And then who can help you with this decision? Who can help you have these conversations? So with that, I'm going to turn it over to Lee.
Thank you, Karen. So I'm a practicing general internist. I see patients in primary care here at Mass General, and this comes up for me every day in practice. In fact, just this morning, I had two very similar themed but different outcome conversations with women in their 70s and 80s about breast cancer screening. One patient said, I'm so glad that you think it's okay for me to continue to get mammograms because I really worry about breast cancer. I'm in really good health and I don't want to have that diagnosis. I don't want to miss that diagnosis, rather. I want to have a chance to treat that and early. And we continued her mammography. She's in her early 80s. Another patient, when her daughter said, I think mom might be behind on her mammogram because of the pandemic, she's in her late 70s. I said, well, we should talk about whether she needs to keep getting mammograms. And the patient herself almost jumped out of the chair and said, I hope not. I hope I can stop. Can we talk about that? So we talked about a plan for monitoring for symptoms, but not doing any mammograms at this time in her life. So can have very different outcomes. The point of this talk is that it's up to doctors and it's up to patients to have productive conversations about a plan that makes sense for you. I'll recap a few concepts as I talk about the individual screenings for different cancers and some facts that you should know, but some general concepts that I like my patients to know about. No test for cancer is perfect. We'll always miss some cancers. Fast-growing tumors may not be able to be seen. They may develop in the interim. You've all probably heard about people who had colon cancer diagnosed only a few years after apparently a normal colonoscopy. That can certainly happen. Or tests elude our current testing. Our testing is not good enough. Other cancers we wish we had never found. They would have never been a problem for you, except that we found them and we feel obligated to do something about it. You've most likely had that experience or heard of people who have had. We always need to talk with our patients about the pros and cons of every test and make a decision with your doctor and discuss it on a regular basis. This is not a decided and then, the case is closed situation. Guidelines change. I'll share with you a couple of very recent guideline changes, and your own priorities for what you want to do may change as well. Next slide, please. A couple of things I always ask for my patients to tell me about, and I usually focus this conversation at the annual visit, but anytime there's a change in your family history, make sure to let your doctor know. A change in family history, such as a diagnosis of any type of a cancer, may have an implication for a genetic syndrome or your own predisposition. So please update your doctor. If you're seeing a new doctor, giving your doctor your history of cancer testing before and the outcomes. Knowing about your smoking history is something you can expect to be asked about regularly. And then some themes that Karen mentioned earlier, but thinking yourself, how worried are you about finding out about cancers early or any particular cancer? And then how worried are you about focusing on other conditions right now that you are dealing with? Next slide. So I wanted to first talk about colorectal cancer screening. And there are some new guidelines on colorectal cancer screening, though we're focusing our deeper conversation on guidelines for people over age 65. I will give you some updates on younger ages because you may have friends and family in your life who you want them to be updated on the latest in guidelines. As of this month, the guidelines have changed for colorectal cancer screening from the United States Preventive Services Task Force. That's a guideline developing body that issues recommendations to doctors and healthcare systems on how to screen for different cancers and other conditions. As of now, it's recommended that we start offering screening to people at age 45 for colorectal cancer, for bowel cancer. This screening should continue at least until age 75, as long as clinically appropriate. And then people age 76 to 85 need to have a conversation with their doctors about whether continuing to screen makes good sense for them. And in general, most people over age 85 should not have screening tests for colon cancer. That is different from having workup of a symptom like bleeding or a change in your bowel habits. That's called a diagnostic test, but a screening test, meaning no symptoms, generally doesn't need to be continued after age 85. Another important thing to know about, you've likely heard about different options for colon cancer testing, colon cancer screening. Colonoscopy is what we're very familiar with. And if it's normal, and a colonoscopy every 10 years is very reasonable, but may have to be done more often if polyps are seen. Those are precancerous growths in the colon that are usually removed at the time of colonoscopy. We have other options of tests that you can do at home or start at home. A FIT test or a stool card test for blood that can be mailed back to the doctor's office. That's done once a year. If it's abnormal, a colonoscopy is recommended. And then the Cologuard, where you mail an entire bowel movement to a laboratory, a lab in Wisconsin, actually. And that's done every 3 years. And if normal, if it's abnormal, it's recommended to have a colonoscopy. A couple of things you'll want to discuss with your doctor. If you have a family history of colon cancer or polyps, you may need to be tested earlier than the recommendation of age 45. I should update that slide here, or continue testing at older ages. If you've had a personal history of polyps, you'll want to tell your doctor about that because that could impact your screening plan. Also, if you have polyps found on your colonoscopy or colon cancer, tell your family members because they will need to discuss that with their own doctor. So your children and your siblings should be aware of that. That might alter their plan. Next slide, please. Next is lung cancer screening. There are also updated guidelines for lung cancer screening. This applies to people who have smoked in the past and smoked to some significance. Lung cancer screening with a CT scan using low-dose radiation dose is recommended once a year for the following people. And you have to meet all of these criteria, not just one. You need to be between age 50 to 80. You need to have smoked at least 20 pack years. And what that means is, for example, a pack a day for 20 years or a half pack a day for 40 years. That's how that's calculated. And your doctor can help you with the calculation of that. That even applies if you smoked intermittently. You smoked for 10 years and then you stopped for 5 and then you started up again. As long as the total is 20, that's what matters. You need to have been a smoker or current smoker within the past 15 years. And then finally, the final criteria is that your health must be deemed good enough and you must have a desire to be treated for lung cancer if it's found. So if someone is dealing with another serious health condition and their doctor doesn't think they could tolerate treatment for lung cancer, you may decide with your doctor not to proceed with lung cancer screening. There are a few things to know about the CT scan for lung cancer. One is when you do a CT scan, it's covering the neck all the way down to the upper abdomen. That means that radiologists may find things like thyroid nodules. They may find calcifications on the coronary arteries. They may find nodules on the adrenal glands that sit above the kidneys. These are things called incidental findings, but just because they're found almost by accident doesn't mean that they wouldn't be important. So there's always the possibility, and that can be a good thing or that can be a stressful thing depending on the outcome. But just be prepared that your doctor may say, you know, it turns out no lung cancer or no nodules that we need to watch, but we did find that you have a spot on your adrenal gland we need to look at, or we need an ultrasound for your thyroid. Those are really honestly expected. And I'm often surprised if I'm not given a recommendation to follow up on some other part of the scan for my patient who had a lung cancer scan. If you are a smoker, part of the deal with accepting a lung cancer screening scan is having smoking cessation counseling. In fact, Medicare does not pay for the scan unless the doctor documents that she or he gave gave smoking cessation counseling along with the scan. So we remind people that it's important, of course, to focus on the quitting smoking, as well as doing the monitoring if they're hoping to avoid illness from lung cancer. Next slide. Next is breast cancer screening. So breast cancer screening, generally done by mammography and clinical breast exam, should be offered to all women aged 50 to 74. And women in their 40s and over age 75 should have individualized discussions about both the benefits, but also the potential harms of screening. A few important things that your doctor will want to know are there women in your family who've had breast cancer? Have you had chest radiation, most commonly for Hodgkin's lymphoma? Those will be important pieces of your own personal history that your doctor would want to know. Again, family members and a personal history of chest radiation, family members with breast cancer or ovarian cancer, because that would determine your screening plan. And your doctor may even do a risk calculation for your lifetime risk of breast cancer to make a decision about the best plan for you and whether or not you need a breast MRI in addition to a mammogram. Most women after age 75 should have a focused discussion with their doctor about their personal risk of breast cancer and other health conditions that they're considering or dealing with. For many women who are in excellent health and anticipated to have a prognosis of 10 years or more, it may make plenty of good sense to continue with mammograms. For women who are dealing with other serious health conditions, this may fall lower on their list of priorities and could instead be done just with a clinical breast exam yearly. Next slide, please. Cervical cancer screening. So this is screening for women for cancer of the end of the uterus. Women aged 21 to 65 are given cervical cancer screening. This is a change. For years, this was started at much younger ages, but now cervical cancer screening does not start until age 21. This is for a couple of reasons. One is the testing has become more sophisticated with human papillomavirus testing that helps us understand the cell changes and how risky they are. The second is the appearance and the broad use of the human papillomavirus vaccine, which has sharply reduced the incidence of invasive cervical changes that can be precancers in young women. So most women are screened regularly from age 21 to 65, but not at the yearly interval that used to be the case. Not that long ago, when I was in my first years of my residency, all of my women patients in my primary care clinic were getting pap smears every year. Then the interval changed every 2 years for some, and then every 3, and now every 5. So I tell my patients I have so much I can much more time to talk to them because we're not caught up with doing pap smears every year at a physical. So the interval is longer. And then some women will need to continue the pap smears after age 65. Most do not, but some women do. If you've had cell changes, precancerous changes, your doctor may recommend continuing it. Also, if you have immune compromise, like HIV disease or on certain immune suppressant medicines, talk with your doctor about whether it's recommended that you continue, because human papillomavirus infection, which is what causes most cases of cervical cancer, is much more likely to be a problem for you if you don't have a robust immune system. So that's an important consideration with your doctor. If you have had a hysterectomy with removal of your cervix as well, you don't need pap smears anymore. Have a conversation with your doctor about whether those need to be continued. As I mentioned before, human papillomavirus is now being vaccinated against for most young women and men, and teens is when it starts, but that's continuing even up into the late 20s. So this may not be an illness that your grandchildren have to think about, which would be a wonderful thing. So you'll expect that we'll hear that pap smears are maybe done even later in life and less frequently, but these are the current guidelines. Next slide, please, Karen. And then finally, prostate cancer screening. our work is in what we call shared decision making with our patients on important decisions around tests and treatments, where your own input as the patient is really important on deciding what to do. And the testing for prostate cancer is kind of a classic case for high quality shared decision making to make the right plan. This is because though prostate cancer is very common, many more men will be diagnosed with it than actually die of prostate cancer. And that means we detect a lot of it and treat a lot of it that might not have caused a problem for the man. But it's a common cancer, and it's one that that is still one that impacts many people's lives. And knowing about how to be tested for it and how to manage it if you have it may be very important for many patients. So all men over age 50 should start the discussion about prostate cancer screening with their doctors. And testing currently under those USPSTF guidelines I mentioned is currently recommended with a PSA blood test from age 55 to 69. Most men over age 75 should not be screened for prostate cancer anymore. They may be diagnosed with it because of symptoms, or it may be diagnosed incidentally, but screening, meaning having no symptoms, probably shouldn't be done after age 75. That's mostly because it's a very slow growing tumor. You may die with it, but not of it. Testing is done in two ways: by a digital rectal exam at the time of a doctor's office visit. Not a terribly accurate test. It will not pick up many cancers. It's not a very comfortable test. And so not all doctors are still offering it, but it may be appropriate in some cases. And then the prostate specific antigen PSA blood test done every 2 to 4 years. Men who have a strong family history of prostate cancer may be appropriate for being screened early. And that should be a conversation with your doctor. And it's important to note that the guidelines on this have shifted really dramatically over the years, and it's important to stay up on this and remain in conversation with your doctor about it. All right, that's the end of our presentation on the specific cancers. So we'll stop here and let Susan guide us on next.
Susan, you're muted.
My apologies. I think we're going to go on to Dr. Russell, and then we'll come back for everybody's questions. And I would encourage you to please add questions to the chat. And I have some of my own that I'm going to share after Dr. Russell speaks. So go ahead.
How do I unmute? There we go. Well, happy, beautiful weather day for those of you who are in the Boston area. It is definitely a day that no one wants to sit in front of a computer less than us, but it's wonderful to have this great information because it also helps us as the frontline folks having that conversation with you all. So thank you to our two speakers. Really appreciate it. So we're sort of coming to the end of an academic year in our training program. So I thought it might be a reasonable time for us to just review our practice model. And I'm calling it a senior health primer. And I hope that this is, that you'll find this useful. So one thing that's come up that I just did want to bring to your attention is for our practice, we have ways that are optimized for the timeliness of what you need if you need to reach out to us. And what I'm basically saying is we really like to hear from you if you have an immediate concern by the richest form of communication that we have, which is the telephone. So for any kinds of issues that require attention during the workday, rather than sending a message through Gateway, please call the clinic. The same thing if something emergent comes up on nights, weekends, and holidays. You can call the clinic and ask to speak to the physician covering for the senior health practice. So that's one of the 5 or 6 of us that are doing that. We really want to drive home the point that Gateway is for non-urgent, non-emergent communication. If you're having chest pain or shortness of breath, or you're bleeding, that is not an email to us. That is a phone call and quite possibly a 911 call. So we just wanted to let folks know, because sometimes we get messages on Gateway that we might be in clinic and we're seeing other patients. We don't see that for hours, and we don't want you to miss out on urgent or emergent treatment. The last thing just about our communication is for virtual visits. So for those of you who are in Massachusetts who are able to do virtual visits with us, a lot of times you'll log into the waiting room and you say, geez, I've been waiting here for a couple of minutes. The doctor isn't here. Did I do the right thing? Yes, you did the right thing if it says you're in the waiting room, and it usually means we're running a little bit behind and we'll join you shortly. So we just ask you to give us a little breeze of time to get back on track with you, and preferably not to call the clinic if we're not there right away. Next, I'll just move on to some senior health transitions. So as we've said on these town halls previously, our practice will eventually be moving to the Yawkey building on the second floor, which is on the main campus. That date is still to be determined. So we just want to keep it on everyone's radar in the event that we're told it's in a month. And we always advise you, if you're coming in person in the next few months, please check to make sure that you are going to the right place. Next, we have some staff transitions. So many of you may know that our Dr. Nunez will be leaving us in June. He's going to be going to be closer to his family in Florida. We are currently recruiting for another physician. So fingers crossed, I'm sure we'll get a good candidate. And lastly, our geriatric medicine fellows, Dr. Meenakshi Dagar and Dr. Melissa D'Souza, will be finishing their fellowships and graduating this June. Our new geriatrics fellows will be starting in July. And that really helps us get a sense of what it is that we do as an academic practice at Senior Health. So we just thought it would be helpful to let you know how we're seeing the practice grow and develop from our side. It is a collaborative, interprofessional, and team-based care for affirmative aging. Now, an academic clinical practice has staff, providers, and staff administrative support, but also physicians and nurse practitioner students, physician students, nurse practitioner students. So we have in our practice at present attending physicians. That's sort of the staff physician. That's the doctor who stays. That's not the doctor who's doing training for a year or two. We also have medical residents and geriatric fellows, and I'll explain that in the next slide. For our nursing division, we have nurse practitioners. These are advanced practice nurse practitioners who are master's level trained and able to assist in the care of the patients with us. We also have a nurse case manager whose role is to help us coordinate care in the community and also with transitions of care. And then we have our clinic nurse, who is usually the first person you speak to after the front desk if you have any questions or concerns. We also have a social worker and sometimes have social works interns. We have our medical assistants who help get you in the room with your vital signs, also draw blood, and they do some care coordination behind the scenes. Our administrative staff include our front desk, who helps to schedule and support our patients. They also do a lot of, again, behind the scenes coordination of paperwork and medical record transfers. And we also have an education coordinator, someone who helps us make sure that the physicians in training and the nurse practitioners in training and the physician assistants in training are showing up and getting a good experience with us. I think it's really helpful just to explain what a physician training hierarchy looks like. So just to review, a medical student has completed a 4-year university degree and now is in a 4-year course of study to become a physician. So we may have medical students who are doing a medicine outpatient rotation, and they may spend time with us. They are not a fully fledged physician, but they are great at taking the story down from a patient and spending time with the patient to get more of that story. A resident is someone who has completed medical school and is licensed as a practicing physician within a training program. And that can last anywhere from 3 to 5 years. So these are people who will call doctor, and we're training them in the course of their study in all of, for example, internal medicine. Lastly, we have our fellow level. So a fellow is a physician who has completed a residency in internal medicine or family medicine. So they've already done, they're fully fledged doctors. They are ready for independent primary care. They're just choosing to prolong their training to receive additional skills in geriatric medicine. Now, why do we do this? What is geriatrics versus regular medicine? So this is my boat analogy, my nautical analogy. I'll describe internal medicine and the primary care most of us receive through our working years as you're the captain in a rowboat. It's pretty clear when something is wrong and you are steering your ship and you know very quickly which way it's going. So in geriatrics, we feel that team-based care is better. We want our patients to have more sets of eyes on them. That means physicians, nurses, social workers, and trainees, because they all see things in complementary ways. So in our practice, you will see both your physician and your nurse practitioner during a year. But it's important to know that your doctor is not the only one taking care of you. And we think that's a good thing. And the reason is because as we get older, we are no longer in a rowboat. We are now the captain of a cruise ship. And we need a team of people to help us, because it's sometimes not clear if this is a matter of chipped paint on the deck or something serious going on below the waterline. With that, I've finished my slide. We've got beautiful lupines and a mountain view. I'm going to stop sharing and just to say that it's really wonderful to have this style of care. Many patients who I follow with a geriatrics fellow. And yes, that person does rotate year to year. And I don't. I stay here. So I get to have that experience with my patient and also have another set of eyes on my patient, which is a good thing. You want to make sure that you've got a good 360 view of people looking at you. In case one of us misses something, another one will see it. All right, I think that's all I have. It was very lecture-y, I'm sorry, but I hope you enjoyed.
Thank you. So we've got a couple of questions, but before we move to those, I have a question for Dr. Sapuka and I have a question for Dr. Simmons. So my question for Dr. Sapuka quickly is, given that we've got this incredible resource at Mass General, the Health Decision Science Center, could you just say a few words about what the center does and what kind of resources people can access? And we've put the web link to the center in the chat for everyone. So I would encourage everybody to click on that so that you can also see all the different resources and activities that are being conducted at the Health Decision Science Center. And then I'll give Dr. Simmons her question.
Yeah. So our group really looks to figure out what we can do to advance the science to really help people make better decisions, and then take what we know from the science and evidence and then bring that to our patients to put that into practice. So one of the big things is, one of the big challenges with a lot of decisions is trying to figure out what is that information? What are my options? How do I understand my risk? How do I understand, sometimes we don't always have all of the information and there's uncertainty about what might happen, and how do I make a decision when things maybe aren't so clear. So we try to pull tools together. There are tools called decision aids that we have that are available that pull that information together to help people really think through and get informed, and then it also helps them think through what's most important to them, sort of like those reflection questions that we had here, to figure out how do they have a conversation with their doctor, to figure out what treatment might be best for them. So we do a lot of work to get good information to patients. And then on the clinician side, we do a lot of work to train our docs. How do you communicate about these things? We never have enough time in the visit. So how do you do this, efficiently? Where are the areas that we can give them insight into how patients are thinking, what they're thinking and what they're feeling? So we do a lot of work both to try and train our clinicians and to get good resources to our patients to make sure they're making good decisions. And really the goal is, making sure that we've got our patients that are informed, they understand what's important, and then that we're matching the right treatment or test to the right patient. So we're doing what's most important to them.
Can you just say a little bit quickly about where to access some of the decision aids on Patient Gateway?
That is a great question. So I think there's, patients can access them directly through Gateway. I think there's a health information tab, I think, in Gateway to get the information. And then also there are tools if there's specific decisions that your physician can actually, actually place an order for the information, and then it'll get sent right to you via Gateway, and you can look at it online. And the nice feature about some of these tools, there's some questions that are embedded in the online tool. So they give you some information, and then it has some questions. And then when you finish looking at it, a report gets actually sent back to the doctor, so they know what you looked at, and also what you're thinking, where your sort of preferences are for that piece.
So my question for Dr. Simmons is based on research that several of us were involved in many years ago, where we looked at when people had made some sort of significant decision about surgery, prostate cancer surgery, breast cancer surgery, other things that are very important. We wanted to know, before they made that decision, did they get information about the risks of the different options that were being offered to them, about the benefits, and were they involved in the decision making? Or was it, sometimes people joke that shared decision making is the doctor makes the decision and shares it with the patient, rather than it being a partnership of doing that. And one of the things we found is that people heard a lot about the benefits of pretty much everything. They didn't hear much about the risks. And part of what I think Karen and Lee's work is to really try to make sure that you get both sides of the story. So I'm going to ask Dr. Simmons if you can just say a few words about what are your recommendations for us as patients about how to engage in that kind of conversation? Because I think many people are afraid if they ask a lot of questions, they're going to offend their doctor.
Yeah. This is something I encounter a lot. I don't do knee replacements. I don't take out lung nodules that are worrisome, but I sure see a lot of people for whom I've referred them on. And so some things I like to prepare them to ask are things like this. How likely am I to benefit from this proposed procedure? I recall working with a patient who was really agonizing around a decision on an orthopedic procedure. And she and I both realized that we had no idea how likely the surgeon thought that the treatment would work. We didn't know. And I had no idea it was an unusual procedure. And she said, well, I assume it's 100%. I said, oh, I can tell you it's not 100%. Nothing is. So let's find out, because wouldn't that help you with knowing whether or not to go on, or how likely is it that you'll improve on your own? So I tell my patients how likely is it in your experience with this procedure? What have you seen? It's perfectly fine to ask the doctor in their experience, because that may be different from something you've read online. And they may be able to say, well, the patients I select and offer this to, here's what I have found works best. And here's the team I work with to get that outcome. That kind of thing is important to know. I often to encourage my patients to to make sure that that as they're facing something major like this, that they've brought along somebody who can help them take notes, or to ask the kind of questions that you might not think of. You know how when you're asked on the spot to name a bunch of things or ask all the questions you can, and you just all of a sudden are blank. Bring somebody who won't turn blank and can keep writing notes for you. During COVID, we've had challenges with people not being allowed to bring in somebody to the office. And the way I've gotten around that is I call a lot of people's daughters on the cell phone. I say, oh, could you please call Jessica right now? Put her on speakerphone. Let's go ahead and talk through things, because maybe she has some other things that she wants me to know about. So just having a support person there to ask those questions. And most doctors are going to want you to do that because they'll want your questions answered. We do not want to deal with hearing after the procedure has happened and after there's been a complication to hear, oh, my spouse didn't want me to have this. Oh, it would have been really nice to have a chance to do that, to know in advance.
Thank you.
Yeah.
So we have, I think, a very important question here about how do you override ageism in cancer screening? So, for example, some GYNs simply will not screen for issues such as fallopian or ovarian cancer if you are over 65, even if you had a sister with that was diagnosed at age 50 and died when she was 55. So can you say a little bit about that? Because I think that's a concern that a lot of people have.
Yeah. Oh, it's a real concern. And so I think something really important to remember is in the general population, health status can stay very much the same among age groups until you hit a split around it's certainly around age 75, sometimes even earlier. And one person who's 75 is not the same as another person. Your health status may be so different. And for one person, it's extremely reasonable to continue screening for conditions that are not causing symptoms yet. But you would really want to know if you had this condition, because you'd want to treat it early. And somebody else may say that is not an important thing. I need to work on my diabetes, or I have dementia, and that's what I'm focusing on. So I think there is a fear that things are ageist when these recommendations are made, and asking your doctor, why do you not recommend this test? Or sometimes I find it helpful to hear from patients, I understand that this test might be painful. I understand that the biopsy that might not yield a result. I'm okay with that. I accept that. Sometimes that's really helpful to hear. It's also important to ask your doctor, why do you recommend it or not recommend it? Because maybe they know something you haven't heard about, or you know something about yourself, of course, that they don't know. And they may be able to say, actually a study has come out recently showing it's not a good idea to do that test to look for that problem. And that may be different from what you heard 10 years ago when you and your doctor were doing that. So I would just probe a little bit more and say, oh, that's interesting. Why do you recommend I do it? Or why do you recommend I don't? And then anything you think about yourself that's important for them to know.
Thank you.
And Susan, if I could add to that,
Sure.
I often will say to patients, especially when we're having a discussion about mammography, because breast cancer is so common, that people may have personal experiences that actually have nothing to do with their personal risk. So, your best friend had breast cancer, or your neighbor had it, or your neighbor had a mammogram at a young age and had to deal with biopsies and problems from a false positive. There may be a personal experience that doesn't impact your risk at all, but it may very much impact your desire to be tested or not to be tested. And so I will sometimes mention that to patients and encourage them to mention that to others, to say, the reason I feel so strongly about this is because of this reason. Again, it may not impact your risk, but it impacts how you feel about how you want to proceed. And that's important.
That's great. That's very helpful. Lee, there's another question that I'm going to direct to you, and that is for men who have an elevated PSA.
Yeah.
What are the guidelines about them also, once that you find an elevated PSA, when do you also do an MRI?
This is an area that is rapidly evolving, but it's very interesting. And it actually, for many men, has lowered their concern about doing PSA testing, because an elevated PSA may not always lead to a biopsy. It depends on a few things. It depends on the skill of the urologist in how comfortable they are using an MRI to tell them whether they need to be worried about a prostate cancer. So there's a reason an MRI can be helpful. A PSA is a blood protein that can be high in an enlarged prostate, a benign condition, or high in a prostate cancer. It's usually very low for men who don't have prostate cancer, but not always. And if it's very low, the chances of prostate cancer are slim. But if it's high, we don't know exactly what that means. And so an MRI of the prostate, so an MRI of the lower half of the pelvis, can show you if there are any spots in the prostate that might be prostate cancer. So a high PSA, but a normal prostate MRI would indicate maybe this man has benign prostatic hypertrophy, and that's why his PSA level is high, but he doesn't seem to have a cancer. Some urologists, in some places, prostate MRI are not easily accessible. Here in Boston, they are, and our urologists are moving toward using them earlier. So I wouldn't say that every man should have one. If he has a high PSA and a nodule that the doctor can feel on exam, that man is probably going to go ahead and have a biopsy. But increasingly, they're being used to decide whether to do a biopsy. And then after a biopsy and a prostate cancer diagnosis is made, the MRI is being used to determine any extent of disease spread.
Thank you. I don't think we have any more questions, but I'm going to ask another one. I know in the past we've had decision aids that did an excellent job showing, like if you were thinking about colorectal cancer screening, what the likelihood, if there was a finding, would mean in terms of any significance to you, in terms of how the data was displayed. Are there other good websites or places for people to go where they can access this kind of information in addition to what's on our patient gateway or what's at the Health Decision Science Center?
That's a great
Karen?
question. Yeah. So I don't know, Lee, you might have some other options. So one place that I know has a good information for lung cancer screening, although I think they haven't updated it, the guidelines just changed, as Lee mentioned, was ARC. So the Agency for Healthcare Research and Quality has decision aids. I think that's the only one that I'm super familiar with in terms of one that's like routinely updated. Lee, I don't know if you send folks to other places for cancer screening decision aids. I mean, there's.
Yeah, the only one, the other one I was thinking about is, and this one is it's a bit more doctor facing, but certainly patients can use it. Is something called ePrognosis, and it's a website out of UCSF. Dr. Mara Schonberg from Beth Israel Deaconess here is a contributor to this. Her research is on breast cancer screening in older women. And that gives information about, it includes decision aids on 2 cancers, colorectal cancer and breast cancer. And it under their section on decision aids, and again, you can look this up by going to ePrognosis, a little e, big P, but you can type in whatever you want. ePrognosis cancer screening decision aids. And there you can input your information, and a bit of biographical information, how old you are, male, female, height and weight. And what it gives you is a pie chart about whether screening for this cancer at this age, is it clearly beneficial, clearly not beneficial, or somewhere in the middle. So it's a nice starting point for a conversation. It's not the be all end all. I'd still recommend a conversation with your primary doctor, but it is a nice starting point. So breast cancer and colorectal cancer are the 2 that are on there.
Thank you. Any other questions from anyone? Dr. Russell, do you want to have any parting comments?
I feel like I should sing, but I'm not going to. I think that today is a day not to worry about vitamin D deficiency and get outside so it doesn't come and happen to you. These are great discussions that I invite you to bring when you meet with your doctor for your annual wellness visit. everything is the conversation. We have to have these conversations and make sure that, we're not just doing a conveyor belt kind of treatment, because it just doesn't work like that. As Dr. Simmons said, when we differentiate at the ages 75 and on, we have to be managing folks individually. I'll also make a plug for next month when we talk about the Matters Most conversation. So this is a project that we're really hoping for all of our patients to participate in. And it's that you have a conversation not only with your doctor, but also with your loved ones about what's important to you as you're facing this stage of life. And if you weren't able to speak for yourself, what would you want folks to know about your values and how you see what's important to you? So stay tuned. That's a teaser for next month.
I
Join
miss
us next
seeing,
time on Senior Health Town Hall for the stunning conclusion.
I may sing, and that will run everyone out of the building. So I hope you all have a wonderful rest of your day, and thank you so much for this incredibly rich and informative presentation.
Thank you. Thank you.
Thanks to all. Bye-bye.
Bye.